Hello, I'm Dr. Sri Banerjee, and in this video, I'm going to be going over the connection between the occurrence of infection and cardiovascular disease mortality. It is with great honor that I'm presenting this in the Heart and Diabetes Conference being held at Philadelphia, Pennsylvania. So, for starters, when we're thinking about the occurrence of infection, that's a broad topic. Infections can be ranging from eye infections to food infections. So that's not something that is very specific. However, what we decided to do is narrow it down to mostly respiratory infections. Well, before we put the cart before the horse, let's go in and talk about what the problem of cardiovascular disease is, and understanding why infections are so critical now more than ever to better delineate. Um, Current infections, especially at the height of the pandemic, these concerns came to the forefront. Um, for the most part, in the 20th century, many of the infectious diseases, especially bacterial, were treated through antibiotics. However, as time went on, viruses were not well treated, and so the pandemic led to many respiratory infections. And this is why we decided that we were going to select respiratory conditions such as chest cold, head cold, all of these within our consideration in order to see if there's any sort of difference in overall mortality or specifically cardiovascular mortality. So, developing this a little bit further, uh, antibiotics have been the panacea of many of this. Um, However, there's still gaps in how to treat. There's antimicrobial resistance. So, for instance, after a while, microbes, bacteria, they gain resistance due to individuals not completing their antibiotics, or even nosocomial infections may lead to this. So this is a pathophysiological mechanism, and I'm going to, in a minute, zoom into this so that you can take a closer look here. Um, if you look here closely, then you'll find that when here is, I wanted to zoom in a little bit more. So here you can see in this figure how SARS-CoV-2, COVID-19 went into the even to the blood vessels, the pulmonary capillaries, and made disrupted the tight junctions, endothelial dysfunction, which is a perfect storm for creating atherosclerotic plaques. Even increased platelet aggregation, fibrin, increased clotting, and again, this is not something that is ideal within the capillaries, because eventually that can lead to capillary leak syndrome, and also also lead to cardiovascular disease. So if a virus can do this, one of them in the respiratory infection, then others are capable of causing similar damage, and that is the idea behind why I selected this figure. Um, Also, I wanted to bring up the fact that long COVID is something that is a serious issue here, because we're trying to understand which organs are affected. There are 100 plus symptoms that provide long COVID, um, a diagnosis of long COVID. So, transitioning into the methodology again, this was a study that was looking at infections, past and current, at the time of the initial questionnaire, and then following these people up around for 10 years into December 31st of 2019. So the idea is to follow the individuals to their to the mortality endpoint, the mortality outcome. And there is overall mortality and then disease-specific mortality. Well, this is cardiovascular disease mortality that we looked at. According to the ICD-9 codes. So then we also looked at specific respiratory conditions such as influenza, pneumonia, ear infection, head cold, and chest cold. This was all from self-reported data, and this was all conducted from the National Health and Nutrition Examination Survey. And individuals that were 20 years older more are included into the study. So the idea is that despite all of the different advancements, many infections create the perfect storm for cardiovascular mortality. And we don't just see this with chest colds and influenza. In fact, when there's dental work done, some of the infections, bacterial, can seep through into the bloodstream and actually cause an inflammation of the heart. Um, so we've known this for a long time. However, in the context of respiratory infections, how that affects cardiovascular mortality, that's the question. Um, so now looking at the outcomes and the results. So taking a look at some of the results here, um, and I'll point out one slight error here. So the crude infection to non-infection hazard ratio, cardiovascular mortality hazard ratio, is greater than 1. And it's 1.96. And so there's the lower confidence interval and the higher confidence interval. Now there's the error in the lower and higher confidence interval. This value is correct, 1.96. So individuals that had current infection were 1.96 times more likely to die from cardiovascular disease. This is a very important finding because for the first time, there's a connection between infectious diseases and chronic diseases with cardiovascular mortality. Uh, the, the, the fact that infections do not cause long-term consequences is no longer valid. This is why we need to be careful about viruses such as COVID-19, such that they don't cause or we can prevent poor prognosis in cardiovascular health before this takes place. So this was a sex-adjusted, age-adjusted value. This was not purely crude. This is sex and age adjusted, and then this is also adjusting for several demographic and health variables. Now the confidence intervals, lower and upper, are correct here, and this is even after adjustment 2.81 times. So this is not significant because of the wide confidence interval. However, there is still a higher possibility of mortality than individuals who do not have current infection. So what can we do here? I've explained to you what the ramifications are about all of this. What can we do? People with infections, they need better access to care. Infectious diseases primarily affect marginalized populations. So it's critical that we treat and provide health care for all individuals that are undocumented, and so that the overall health can be improved. Also, avoid antimicrobial resistance. There needs to be um, more needs to be done there. And then finally, social determinants of health need to be completely tied into this. And then also, if we look at future studies, then we would need to conduct more robust longitudinal studies. I hope this has given you some insight, and Again, it's a privilege and honor to be presenting in this year's Heart and Diabetes Conference in Philadelphia, Pennsylvania. Thank you for listening.